And I want to introduce Dr. Rong He. She's part of our faculty in the Division of Hematopathology at Mayo. She's been on staff for approximately 4 years and has an interest both in the morphology practice, but is one of our co-directors of our molecular hematology laboratory and also participates in our coagulation area as well. So she's multi-talented. Rong, we're really glad you're here this morning, and we're going to turn over the talk on myeloproliferative neoplasms to you.
Thanks. Is that working? Okay, so I have no disclosures. So objective today, we're going to be very briefly touching upon the common tests used in chronic myelogenous leukemia. Then we're going to focus on the other classical MPNs and talk about the morphologic evaluation, molecular genetic testing in MPN. Then we're going to present you with the diagnostic algorithm that we use at Mayo Clinic for bone marrow evaluation of MPN. Then we're going to talk about some common test utilization issues in MPN. So, okay, so we're going to focus on the classical ones. So essentially the BCR-ABL positive CML and the BCR-ABL negative PV, ET, and PMF. We're not going to touch upon the MDS MPN. We're going to talk very briefly on the CNL due to the recent description of the CSF3R mutation in that disease. Okay, MPN is a malignant hematologic disease that is involving starting from the stem cell. Oh, come on, I can't get it right. And it's effective hematopoiesis. So you're going to have a hypercellular bone marrow with cytosis in the peripheral blood, with or without organomegaly. The fibrosis is common. They usually come with very little or no dysplasia, and the ET, PV, and PMF are classified on the predominant cell lines that are being involved. So CML is a genetically defined disease. With the discovery of imatinib, the tyrosine kinase inhibitors, its overall survival has greatly improved. So therefore, the therapy response monitoring has become very important. And there are multiple genetic testing for CML. And each one has its own indication depending on the time points in the clinical course as well as the patient therapy response. So chromosome analysis, FISH, qualitative PCR, ABL kinase, we have strict, well-defined guidelines on when to utilize them. The FISH can be performed on peripheral blood, and it can detect the rare cryptic translocations that can be missed by chromosome study. Qualitative PCR is done at time of diagnosis. It's a multiplex testing which will identify the fusion form of the BCR transcript. 99% of the time it will be a P210. However, there are sometimes very rarely you will see P190, P230. So once you know which fusion form it is, then you know which quantitative assay to order. And then the ABL kinase domain mutation analysis becomes important when the patient is not responding or is progressing or is losing response on therapy. And identification of the specific mutation in the ABL kinase domain will also guide on your drug switch. So this is the LeukemiaNet recommendation for the genetic testing in CML. I'm not going into details due to the time constraint. There's also NCCN guidelines being updated on the internet, and you can refer to that for update. Switching gears and talk about the Philadelphia chromosome negative classical MPNs, the ET, PMF, and PV. The diagnostic approach should be an integrative one, so we should put together the clinical finding with the laboratory results, morphologic evaluation, as well as the genetic data. What's wrong with this? Okay, so the role of the morphologic assessment over here is first to establish the diagnosis of an MPN, and then try to subclassify it, and then to evaluate the degree of myelofibrosis, and then lastly to assess the percent of blasts and rule out transformation. So morphologically, classical findings of MPN, in peripheral blood, you will see the dacrocyte, most commonly associated with a myelofibrosis, and large and hyperlobated or deeply lobated megakaryocyte on the aspirate, and typical finding of megakaryocytic clustering, tight clusters defined by at least 3 megakaryocytes touching each other without any intervening cells, abnormal chromatin pattern. So after we have identified or made sure this is an MPN, then we're going to try to classify it. However, we have to be practical here and acknowledge that we cannot accurately diagnose, subclassify every single case. So the approach we should take here is first try to rule in or rule out a PV. By morphology, sometimes it could be challenging because PV can be a great masquerader morphologically. However, the lab result will be able to help you in this situation because PV is the only disease in this category that will have a primary erythrocytosis with a secondary decreased EPO level. And all of them essentially are JAK2 mutation positive. So once we had ruled out a PV, next step is to diagnose the clear-cut ET and clear-cut PMF. Anything in between with overlapping features, we're not sure, they're your MPN NOS. This is the same thing in just a flowchart format, ruling out PV, and then if that's ruled out, diagnose ET and PMF on the 2 ends of the spectrum. They do have different overall survival and different clinical intervention scheme. This is the WHO criteria for diagnosing PV with 2 major criteria, including erythrocytosis and presence of a clonal marker, and minor criteria with bone marrow hypercellularity with trinity hyperplasia, decreased EPO, or endogenous erythroid colony formation in vitro. To make the diagnosis, you would need either both major plus 1 minor, or having the erythrocytosis and plus 2 minor. For PMF, the WHO criteria include a morphologic feature of MPN, ruling out other myeloid neoplasm, presence of a clonal marker, if not, rule out the reactive causes. And this one, there are also 4 minor criteria, and you need at least 2 of them. And practically, a clear-cut PMF always comes with neutrophilia, thrombocytosis, and cytopenia, sometimes most commonly with anemia. The cellular phase PMF will have a hypercellular bone marrow with or without fibrosis. Granulocytic hyperplasia is a feature, as well as the prominent megakaryocytic hyperplasia and atypia. So this is from an 80-year-old guy, hypercellular bone marrow, granulocytic hyperplasia, tight megakaryocytic clustering, and highly atypical nuclear feature of the hyperchromasia, and coarsely speckled chromatin with nucleoli. When the disease progresses, you'll start to have decreased cellularity, increased background myelofibrosis, osteosclerosis, and dilated sinusoids containing hematopoietic precursors. The WHO criteria for ET include sustained platelet count of higher than 450, morphologic features of an MPN, ruling out other myeloid neoplasms, and presence of a clonal marker, if not, ruling out of other reactive causes of thrombocytosis. Practically, a clear-cut ET will show a normal to slightly hypercellular bone marrow. The neutrophils in the peripheral blood is usually less than 12, and there is little or no granulocytic hyperplasia in this instance, no or very little reticulum fibrosis, and there should be no marked megakaryocytic hyperplasia or atypia. This is a bone marrow from a 40-year-old guy. You can see the megakaryocytes here. They are loosely clustering, and we do not really have many of the highly atypical megakaryocytes showing the hyperchromasia as we saw in the PMF cases. no reticulum fibrosis. So over the years of research, multiple distinctive genetic abnormalities has been identified in MPN, both on the cytogenetic and on the molecular level. This is the major molecular landscape for Philadelphia chromosome negative MPN. And the three major driver mutation is JAK2, CALR, and MPL. Very importantly, they are exclusive of each other. And the most common one is JAK2 V617F, highlighted in red. It's account for higher than 95% of cases in PV and 50 to 60% of ET and PMF cases. In PV, the rest of the cases are essentially positive for JAK2 exon 12 mutations. In ET and PMF, the next common mutation is CALR mutation, which was first reported last year at last year's ASH. And then after CALR, the next most important mutation is the MPL mutation. And we still have about 7 to 10% of ET and PMF cases. We do not have a major molecular signature for it. So going into the specifics of each marker, okay, the JAK2 V617F mutation, a positive result will support the diagnosis of a myeloid neoplasm, and it strongly favors a MPN over MDS. However, in a small percentage of MDS or AML, you will have a positive result. Positive result will not help you to distinguish different subtypes of MPN. A negative result generally is diagnostic not helpful because the patient can be positive for other mutations. However, it does argue against the diagnosis of PV or post-PV myelofibrosis. The assay sensitivity depends on the platform that is used. Sanger sequencing comes with a standard sensitivity about 20%. Now more and more people are using the quantitative PCR. Usually the sensitivity is less than 0.1%. However, a word of caution here is to be very careful with the very low borderline values that have been reported in apparently healthy volunteers. And the same that goes with any quantitative assay when you're at that borderline level. So whether we should test do the test on both peripheral blood and bone marrow, and we asked that question. Theoretically, you should not need to, because it's effective hematopoiesis. What's in the bone marrow is circulating in the peripheral blood. So we did look at our test within a 3-year period, and we identified 267 patients with concurrent peripheral blood and bone marrow testing ordered, and the concordant rate is pretty high. It's 98.5%. Concordant. We only identified 4 discordant cases. When we drill down and look at the value, and all the positive results were at the borderline. And when we look at the morphology of the bone marrow, we have one that is MDS, MPN, the other 3 showed normal morphology. So if we had just ordered one test, we would not have any change in the diagnosis, management, or the outcome of the 4 patients. So the conclusion is to cancel the duplicate test and just do it on one type of specimen. The second test is Calreticulin, which is the second most common mutation in ET and PMF. So Calreticulin is a multifunctional protein, and all the mutations identified in MPN are insertion deletions involving the last exon of CALR, resulting in the same alternative reading frame on the C-terminus of this protein. And CALR mutation has been found in the stem cell as well as the progenitor cells. It's also converging on the JAK step pathway like the JAK2 and MPL. So JAK2 and MPL mutation have been demonstrated to be adequate to cause an MPN phenotype just by itself. And CALR mutation, there's a presentation at this ASH meeting from a French group reporting that the bioretroviral mouse model CALR mutation is adequate to cause an ET phenotype with progression to myelofibrosis. And the sensitivity for detecting the CALR mutation also depends on the platform. Sanger sequencing 20%, fragment analysis 5%. MPL exon 10 mutation, is seen in 5 to 10% of PMF and 3 to 5% of ET, essentially mutually exclusive of JAK2 and CALR. It's commonly done by Sanger sequencing with a 20% sensitivity. So besides the diagnostic value of the 3 major driver mutations, they also carry prognostic value in the PMF. CALR mutation has been consistently demonstrating a favorable impact on the overall survival, and it is independent of the risk stratification scoring system, whereas the triple negative molecular signature, that is negative JAK2, CALR, and MPL, they are a high-risk molecular group. Besides those 3 markers, there are other genes that has been identified to carry prognostic value. Most of them are the epigenetic modifiers, like the ASXL1, IDH1 and 2, EZH2. However, when they do the multivariate analysis, only ASXL1 remained significant, and also additional high-risk molecular markers identified is at least 2 mutations, a CALR negative, ASXL1 positive group. So all this 3 group will have a reported median overall survival of 2 to 3 years. Again, good prognosis in CALR. Additionally, there's also report of NRAS association with a high DIPS scoring, as well as TP53 mutation association with loss of heterozygosity is associated with quick leukemic transformation. So it has been proposed by multiple groups to incorporate the molecular signature into the risk stratification of the PMF. Currently, it's not there yet, but it's going to happen likely soon. Lastly, the JAK2 exon 12 mutation, again, it's only occurring in PV. Not in PMF and AT. So this test should only be ordered when you're suspecting PV and your JAK2 V617F is negative. It's commonly done by a Sanger sequencing. It's not the appropriate testing if you're looking for screening for JAK2 V617F. Firstly, because the JAK2 V617F actually occurs on exon 14 rather than 12. However, if your testing actually goes to exon 14, this will be a lot less sensitive than an allele-specific PCR. So I've shown you that the evaluation of the 3 major markers has diagnostic and prognostic value. So we should incorporate them into our workup for the MPN. However, the genetic testing, they are complicated and also costly, so we should use this molecular landscape in guiding our test utilization in those situations. And luckily, they're essentially mutually exclusive of each other, so we can use this one. So we should always test for the most frequent mutation first. If that's negative, then go to the next common one. So with that in mind, this is our algorithm for a bone marrow workup for MPN. It looks pretty busy, but the bottom line message here is if you're suspecting PV, those are the 2 tests that you should order. And you should only do this exon 12 if this one is negative. If you're thinking about ET and PMF, start with your JAK2 V617F. If that's negative, go to CALR. Negative, then go to MPL. So all our tests for evaluation for MPN in the bone marrow start with a chromosome analysis. We always do that. A quick BCR-ABL qualitative testing or FISH testing to rule out a CML. Always do JAK2 V617F, then follow the algorithm. And if BCR-ABL is positive, then you get your diagnosis of CML. Okay. If that's negative, get it to work, and look at your bone marrow for morphology. If there's no morphologic features for MPN, is there any feature of erythrocytosis in this patient? If there's no erythrocytosis, then essentially you're done. If yes, there's erythrocytosis, then follow with the erythrocytosis algorithm that Dr. Hoyer is going to talk about after me. If there are morphologic features of MPN or it's equivocal for that, then we continue on with the algorithm. Positive morphologic features of MPN, positive JAK2 with clinical information, we should be able to reach our diagnosis. However, negative JAK2 V617F, then what do we do next depend on whether we're considering PV or not. Looking at the lab value, if there's no feature of PV, the next one we should do is CALR. Positive, then that helps you to reach our diagnosis here. Negative, then we should do MPL. If there are laboratory features suggesting of PV, then we should order the JAK2 exon 12 testing. A positive test helps we establish a diagnosis of PV. A negative one, with a negative in both the V617F and exon 12, it does not support the diagnosis of a PV, so we should revert back to the alternative CALR and MPL pathway. If the morphology is equivocal for MPN, depending on the JAK2 status, a positive will support the diagnosis of MPN. A negative, in this situation, your highest yield testing in this situation is CALR. Positive, help you to reach your diagnosis. A negative one, we should do a MPL. Positive one helps you to make the diagnosis. If it's negative, then the final diagnosis will really need clinical correlation with the molecular finding as well as the morphology. So some of the common test utilization issues in MPN include the JAK2 V617F studies ordered concurrently, so just cancel one. Sometimes you see the exon 12 ordered before the JAK2 V617F study. And as I mentioned, this one is only indicated if you're considering PV, and this is negative. 2 of them ordered at the same time, 3 of them ordered at the same time. Now we're start offering CALR. Sometimes you see 4 of them being ordered at the same time. Multiple BCR-ABL testing ordered in obvious classical MPN cases. Flow cytometry ordered, mast cell or eosinophilic studies ordered. So so if you follow the algorithm, that we will be able to cut out many of the unnecessary testing. And this is a example that of a PMF, which was JAK2 V617F positive. So following our algorithm, we're able to reach our diagnosis with 3 tests, and those are the tests being ordered by the clinician. So we're able to, and this was ordered on both peripheral blood and bone marrow, so we're able to cancel 5 unnecessary tests and still reach the same diagnosis effectively. Another thing is that before we put the algorithm into practice, we did touch base with our clinician and got their buy-in. So they can put down their wish list, but the final ordering falls on the shoulder of the hematopathologist after we review the bone marrow and put it together with the clinical information. So, and starting from next month, our lab is going to offer this reflex algorithm panel through MML that start with the JAK2 and then go to CALR and then go to MPL in a reflexive pattern. And also, coming is our 35-gene panel, mainly targeting the myeloid neoplasms. And this is the link to the algorithm page on the MML website. And very, very briefly, CSF3R mutation in CNL, 2 types. One is the point mutation in the extracellular domain, which are responsive to the JAK kinase inhibitor. The other one is the intracellular cytoplasmic tail, which is a truncation mutation. They are responsive to the SRC kinase inhibitor. In our study, we did not find mutations in a typical CML, although it was initially being reported. And this point mutation T618I is a highly prevalent and specific marker for CNL. So with that, I'd like to thank Dr. Hansen and Dr. Curtin for sharing the slides with me and close my talk.
Thank you, Dr. He. We have time for a question or 2, if there are. Otherwise, we'll move on. One question back here.
Yeah, just a question is with the MPL assay, and I think in the last 3 or 4 or 5 years, I've not seen a single patient who's been positive. And since you're talking about cost, is it cost effective? That's one question. And the second question, there's a very interesting abstract at the meetings here about people with peripheral vascular disease who have an incidence of JAK2 positivity that's higher than your MPL positivity in patients without PVERA. So I'd like to know if you comment about that, and that flaws your algorithm.
So in our lab, we do see MPL mutation, which is, I know it's rare, but it does occur. And from our experience and from our experience and literature, it does fall within this percentage that we are seeing. So we think it is still cost effective. And what? It's a sequencing assay, so so if you do identify a positive mutation, that does support a diagnosis of MPN because it's a sequencing assay. The sensitivity is high. It's not like the allele-specific PCR. When you have an equivocal result, you don't know. If you have a positive MPL, then it is diagnostic for MPN.